Good morning, ladies and gentlemen. Once again, I'm very proud to be invited to deliver my contribution in these prestigious meetings, and I thank you, the organizing committee, for the invitation. My topic today is the non-invasive ventilation through the helmet, clinical and physiological implications. These are my conflict of interest. Well, if we refer to the Berlin definition of the ODS, the addendum of the main publication, once again involving the ARDS task force, focused the possibility of the non-invasive ventilation in general, especially in patients affected by mild RDS. But it's indubitable that during the pandemic, most patients has been treated, regardless their severity, with the non-invasive ventilation, in large part related to the lack of bed into the ICU. So what is indeed pragmatical, represented by our action, was the possibility of using this technique in various conditions. We will refer specifically to the use of the helmet. The helmet is a latex-free transparent PVC hook that is secured to the body through two armpit braces. And there is a plastic ring that joins the helmet with a soft collar, and the seal connection through which you can pass an NG tube. And there are two ports for the inlet and the outlet connected to the different lines, inspiratory and expiratory. And the valves are those of the mechanical ventilator. One of the main things that we have to take into consideration, that by using this device, the presence of asynchronies and other characteristics may make the helmet originally pressure support, when it is used as a pressure support modality, fit better with the ICU setting. Notwithstanding the fact, as I already mentioned, that has been largely used also outside the ICU, even though this use outside the ICU in many different centers was adopted in CPAP modality. If we look at this graph coming from a study by Paolo Navarrese, published in 2007 in Intensive Care Medicine, you may see that depicting the PDI, the transdiaphragmatic pressure, and the pressure at the airways opening in a patient ventilated in pressure support through the helmet, you can see that the start of inspiration at the airways pressure opening is delayed with respect to the initial contraction of the diaphragm. This is the period during which there is a synchrony with the diaphragm, but
el diafragma. Pero en la fase de
the patient start to exhale or stop the electrical activity of the diaphragm here, but the real expiration, the airways opening, starts with a delay. However, if you compare to the use of a facial mask, both the interfaces are capable to reduce the pressure swing, looking at the esophageal pressure, reducing the work of breathing, depicted as TPTB per breath or PTB per minute. Interestingly, if we go to compare the duration of the assistance to the diaphragm, you can see the time during which there is a synchrony of the two devices. You can immediately realize that the times during which the diaphragm is really assisted is very comparable. Then we can conclude that probably, especially by using the helmet, there is no major issue if dysynchrony occurs. Also for another reason. If the patient breathes within a pressurized environment, and even though the valves are temporarily both closed or should close and open, nonetheless, the patient being inside the volume of the helmet can just keep a small amount of volume, just producing a real respiratory work. But it's also true that probably if we would like to achieve a better and perfect synchrony, has been proven that the best way to synchronize perfectly this device is the use of the NAVA, the neurally trigger non-invasive ventilation. And you can see that in these graphs, the synchrony is perfectly in synchrony between the ADI and the ventilatory assist, whilst as soon as you look at the non-invasive ventilation pneumatically triggered, the synchrony is lost. In this situation, the best suggestion to obtain the best performance possible from this device is just to use the pressure support, which is higher, and the respiratory ramp, which is faster. Looking at the CPAP mode and NIV, another problem is represented by the potential rebreathing. We'd always have to keep in mind that the alveolar PCO2 is function of the CO2 production and the alveolar ventilation, the flow that passes through the alveoli. This is a logical consequence that as soon as you use this device in a CPAP mode, you have to use flow rate that exceed the 40 liters per minute in order to avoid any increase of the inspiratory pressure of CO2 and avoiding the breathing. So the message under this condition would be, okay, you may use the CPAP. You can use the CPAP even in certain circumstances outside the ICU. For instance, at my site, we developed a program with the hematologist in order to prevent the transfer of this patient or the hematological patient with acute respiratory failure to the ICU by using an early application of a CPAP through the helmet, achieving good results. The first application in pressure support was from our group in 2002, and where the application could show, respect to the mask, a better increase of DPF, an higher PEEP applied, and less or negligible number of patients who were intubated. One essential point using this device is considering its capability of adopting higher pressure, higher end expiratory pressures. Why it is important? It is important because we have the knowledge that not all the patients have the same percentage of recruitable lung, and having a higher level of PEEP potentially, as has been shown by Gattinoni in a invasively ventilated patient, may be beneficial because can allow a better recruitment of the parenchyma. Interestingly, there is another phenomenon, which is the Pendeluft, articulated in the various zones of the lung. And if you look and compare a patient under pressure controlled ventilation and under assist pressure controlled ventilation, you immediately realize that the inspiratory swing in terms of airway pressure, in terms of Pendeluft in the different zone of the lung is much higher when there is kept the spontaneous breathing. And it is beautifully shown graphically when we compare visually the two different modalities, and where the amount of Pendeluft is much more when the inspiratory, the spontaneous breathing is preserved. Following these considerations, we recently published a paper where we compare the effects of helmet pressure support, continuous positive airway pressure in nasal high flow respiratory failure in terms of physiological effect. And one of the most interesting achievements comparing the three techniques in a crossover randomized way was that the end expiratory lung impedance was much less when the combination of the helmet with a non-invasive pressure support was utilized, and the pendulum effect was indeed much lower with the helmet non-invasive ventilation in comparison to the helmet CPAP or the high-flow nasal oxygen. The graphic representation of the regional pendulum during these three different situations and settings clearly show how the regional pendulum is much lower when the non-invasive ventilation through the helmet with the pressure support is utilized, and the regional dynamic strains is indeed much lower in comparison to the CPAP or certainly to the high-flow nasal oxygen. The application in the randomized trial was done for the first time by the group of Jen Kress in Chicago, and where they could show, comparing the helmet pressure support to the face mask pressure support, the possibility of having less endotracheal intubation when the helmet was utilized, and even a better probability of survival. And the best thing under this condition was that the PEEP applicable through the helmet was certainly much higher, explaining probably a higher possibility of a good recruitment in these patients. We adopted the non-invasive ventilation through the helmet in pressure support in comparison to high-flow nasal oxygen on days free of respiratory support in patients with COVID-19 during the pandemic and with moderate and severe hypoxemic respiratory failure. This study was negative in terms of primary outcome, where the median respiratory support 3 days was substantially comparable between the two different groups, 54 patients randomized to the helmet ventilation and 55 with the high flow oxygen. But as soon as we look at the secondary outcome, the cumulative incidence of intubation, the benefit of the helmet in terms of reduction of the cumulative incidence of intubation was quite evident and significant with respect to the high flow nasal oxygen. Interestingly, the group, the Arabic group led by Yasin Arabi, adopted this technique to treat patients again with hypoxemic respiratory failure due to COVID-19, comparing the non-invasive pressure support to the usual respiratory support or mortality. Also, the study was negative. 159 patients with helmet non-invasive and 161 receiving the usual respiratory support. And in this case, the mortality rate at 28 days was absolutely not significant. And interestingly, when we look at the real composition of the usual respiratory support, we could realize how in this group of patients, almost 70% of them was treated not as a conventional use of oxygen, not with throughout the high flow of oxygen, but with the mask. So this study, more than being a study that compare high flow, was a study that compare indeed the pressure support delivered on the non-invasive modality through the helmet in comparison to the mask. And the other difference respect to our study, even though the Yasin Arabi study did not show difference also in terms of intubation, was also related to the fact that the application of this technique through the helmet was delayed in comparison to what we did during the early phases of the respiratory failure in our patient. Recently has been published a meta-analysis in a systematic review where 36 records were included, and where looking at the different studies published so far, there were some bias with different risks for all the different studies. But if we look at the sample size for all these different conditions, please note that the helmet B-level is indeed what we call helmet pressure support, but the sample size represented by the circles is indeed the smaller one when we look at the pressure support or bi-level delivered to the helmet in comparison to the standard oxygen or high-flow nasal cannula or the face mask B-level. And depending upon the different application and the study included, there were no difference over time, a slight benefit when the helmet has been used. I guess that this graph gives an important message from this meta-analysis. In green, you can see when we refer to the helmet ventilation, regardless in CPAP or B-level, this green represent a more beneficial than other standard possibility, but certainly respect to the standard oxygen. And if you see that, you can see that for sure the helmet CPAP and helmet B-level may have or definitely or probably more beneficial. So this technique, after all, also in terms of mortality, duration of hospitalization, or ICU or ventilator-free days, may be interesting interfaces to be adopted in this category of patients. The guidelines, however, that were recently published were a bit discouraging in the sense or disappointing because due to the lack of solid evidence in most of the different studies analyzed in these guidelines, at the very end, we can see that the panel made statement where was unable to make a recommendation or for or against the CPAP NIL in comparison to the conventional oxygen therapy for patients with acute hyperrespiratory failure. Or there is a very low level of evidence and weak suggestion to use of CPAP respect to the COT, or when there is again a lack of ability to make a recommendation when we refer to the CPAP over the COT, as well as there was the inability to make any recommendation against or in favor of the use of helmet interface in comparison to the face mask. So some disillusion looking at this final statement, which can be my conclusions after this long list of different studies, that helmet non-invasive ventilation can be used, and can be used as we have done, especially in Italy, in severe hypoxemic patients. The helmet has allowed for better tolerability, continuous treatment, delivering an adequate level of PEEP for a longer period of time, and this may explain the goodness of the results, at least in some of the studies. However, we should always look at the indicator of failure, much easier when we look at a mask non-invasive ventilation, at least in terms of an higher tidal volume that this patient have. But we have to look at different situ conditions when we have the helmet, and where probably looking at the PF or the ACOR score that has been published by the Chinese colleague, or a higher severity and higher present organ failure may represent major risk factors. Thank you for your attention.